Hello everyone. Beckett and I are here to talk a little bit about sagittal corrections, specifically using Invisalign and the Carriere motion appliance. As we see here, we have a patient who is slightly more than full cusp class 2 molar and end on canine, maybe even slightly more class 2 on the canine than end on. But essentially, she's class 2. Class 2 skeletal, we would presume. We don't have lateral cephs here to determine that. Don't think this case is severe enough to warrant that. And then less class 2 on the left side. And as we always see, when one side is sagittally discrepant compared to the other side, we'll see a midline shift. Don't necessarily see that here. My next step would then be to look at the joint to see if there's degradation of the joint to learn why there's some asymmetry here. With that said, patient's class 2, very compliant family, somebody that I think this 15-year-old will be able to get this correction very predictably. So what we chose to do is use a Carriere motion appliance, and here is the YouTube video on that particular technique. So we put some sort of button on the lower 6s or 7s. We ask Invisalign to get the cutout. Here they're saying an Essex appliance. We do active treatment on the lower arch with Invisalign while we're doing the Carriere on the upper arch. This is a Carriere appliance. It gets placed on bilaterally, sometimes unilaterally, and then the elastic hooks get put on. And it distalizes. This is an important thing that I've had to deduce on my own in trying to understand what this thing actually does. It's not moving the teeth. It's actually moving the entire alveolus. It's important for us to remember that the alveolus is bone that is morphologically and biologically different than the basal bone that sits underneath that makes up the maxilla. Why is that important? Well, the alveolar bone tends to be more movable if you put on the proper forces. We use these concepts all of the time. We just don't necessarily understand what's actually being done. We are not distalizing the teeth. And the reason why I was confused for such a long time, and Carriere doesn't necessarily do a good job of articulating what's actually happening, I was just trying to understand the force mechanics of distalizing the teeth. We're not distalizing the teeth. All we are doing is we're actually increasing the amount of bone by inducing a distalizing force of that entire segment of teeth. Why is this important? Well, we're not distalizing teeth, therefore we're actually increasing skeletal components so that we have a much better relationship between the upper and lower teeth. Rather than doing surgery, where we would do a mandibular advancement in a skeletal class 2 case or a Lefort where we're going to reduce the upper arch, we're actually increasing the bone to improve the skeletal relationship between the upper and lower arches. Long story short, the Carriere appliance does a couple different things. One is it increases the amount of maxillary alveolar bone. This is an important feature. Orthodontists are always trying to create force mechanics to rotate the upper first molar. This tooth is not necessarily rectangular in shape. It's somewhat rhomboid in nature. The point is that if we rotate it using the term distal in or mesial out, those are terms used by orthodontists to dictate the kind of rotation the tooth is going to be placed under, we can actually decrease the amount of arch length to accommodate the tooth. So you can see here, if we measured from the mesial of the upper number 7, I'm using orthodontic terms in the tooth numberings, I apologize. We'll call that the second molar, to the distal of the second premolar, and we gave that x, that distance x. If we then rotate this tooth, that there'll be spaces here because the x distance Let me take a step back. If that distance is X and the tooth is Y, there's often a difference between those two. By taking advantage of rotation, we gain access to that difference between X and Y so that we can then either distalize the anterior teeth or mesialize the second molar, thereby decreasing arch length. Why are we looking to decrease arch length? Because we want to get rid of the overjet in class 2 cases. So rotation of the upper first molar is a very common thing done in orthodontics using brackets. With the Carriere appliance, this bracket is not actually fixated to the tooth, fixated to the bracket in a rigid manner. There's a rotational component here. When the Carriere appliance is under a distalizing force through the use of the elastic, we get rotation here and distalization. The end result is what you see here. Now, what they didn't necessarily show here is creation of the space here. Oftentimes, we'll have some spaces here that with clear plastic aligners, we need to go and close up. The point is that the difference between X and Y allowed us to decrease the arch length, and now we have a better orientation of the upper first molar. The anterior segment does not have a rotational component to it. This is a fixed pad that has a hook for the elastic that is then bound to the lower teeth. And then we close the anterior segment either through the use of conventional brackets or Invisalign. So that is a Carriere motion appliance. It's important to know they have specific elastics that are much higher strength than conventional orthodontic elastics. Reason being, conventional orthodontic elastics do not necessarily...
Habit Appliance.
Sorry about that. Do not try to move an entire alveolus. We are trying to create alveolar bone and distalizing the entire segment of the upper first premolar to second molar. And I guess some cases if you had a third molar, but I doubt that would exist. These patients have arch discrepancies, therefore the likelihood of the third molar being present is slim to none. So when you use elastics, they have to be the Force 1 and Force 2 elastics. There's a whole separate protocol. If you're going to start doing this stuff, you need to learn that protocol from the Carriere directions. It's crystal clear, super straightforward, scientifically backed, and many orthodontists are starting to use this technique. It solves a lot of problems with sagittal discrepancies, and this was one of the cases that I decided to use it. So this is where the patient started. I'm not going to go into exactly all the buttons and how I decided to go forward with the case, but what we decided to do was place a Carriere to distalize the teeth to correct the molar discrepancies. Again, the left side is not as severe as the right. Again, we're almost full cusp class 2 on the right side. Normally, that's all I would do, and then I would save the Invisalign trays for the Invisalign phase of treatment. Normally, about 6 months to get up to 4 millimeters of sagittal correction with the Carriere, and then you would then start your treatment to then bring the interior upper 3 to 3 or 6 to 11, distalizing that backwards to kind of finish the case. But she had quite a bit of anterior crowding. Sometimes patients don't like the fact that the primary complaint that they have isn't being addressed. So I asked Invisalign to create an anterior set of trays to start correcting this anterior crowding at the same time as the Carriere being placed. I had to tell Invisalign, remove the upper posterior teeth in the treatment plan, and this is what we got. Therefore, they made the trays came back and just addressed the front teeth. Now, one may say a tray that exists between the upper canines isn't strong enough to cause movement of the teeth, and that there might be some truth to that. My goal was just to get some progress, and as it turned out, we got a lot of movement. I think for an adult, that argument could be made. With that said, it doesn't hurt to do it. You're not, if you get 50% movement, you're still 50% farther than you would have been had you not used active aligners on the upper 6 to 11 or upper 3 to 3 while you did the distalizing of the posterior segments. So in summary, you have to make that decision in the beginning. Are you going to treat the upper 3 to 3 while you do the active treatment with the motion appliance? Or are you going to leave it? In this case, I decided to move forward with it, which I'm glad I did. While the upper is being treated, my approach is to always treat the lower. My goal here for this patient was to level the curve of SPE. As we level the curve of SPE, we're going to get a much better occlusal plane. I did that by intruding the anterior teeth and extruding the posterior teeth. The buttons that I ended up choosing, I probably would choose different buttons now, but I chose to extrude the posterior teeth as I intruded the anterior teeth. We're getting into a lot of the specifics of leveling the curve of SPE, which will be in a separate video, but suffice it to say that that was the goal of this treatment. All right. So then, 3 months later, here we are. So this scan was taken yesterday. Anterior, no, we're not that far along. But you can see, let's just start with the lower. We're getting some alignment here. We're getting some extrusion of the posterior teeth, a much better situation from where we started. I always like using this little tool right here, which allows us to compare. So 3 treatment plan. This is the beginning of the treatment plan. If you're going to use comparisons, don't have the toggle switch all the way to the right. That's where the computer wants to go with the current treatment plan. I want to know where we are right now. And then the same with the initial treatment plan all the way to the left. I have called Invisalign several times to try to get them to show us a comparison of the two. Unfortunately, right now, we just have to eyeball it. Obviously, we got closure here. I would love to be able to measure how much intrusion we got and how much relative intrusion, which is extrusion of posterior teeth, we got. But I'm happy to say after 3 months, that's a pretty good outcome. On the top, let's take a look. So this was the beginning on the left. This is where the patient is now. Again, I wanted to create a space distal to the canine. That was the whole objective. In 3 months, we gained about 1.5 millimeters of space, which means we're starting to get some correction of the sagittal discrepancy. This patient, unfortunately, was given elastics that were normally intended for Class 2 corrections with Invisalign trays only. Those are very weak elastics compared to the strong forces that we need for the Carriere appliance. So we switched those out after 2 weeks. So this active treatment with the Carriere motion appliance is actually even less than 3 months. Like I said, we're looking for about a 6-month window. The older the patient, the longer the time. But for adolescent patients, growing patients, we should be able to expect a full cusp Class 2 correction with the motion appliance within 6 months, if not faster. So we can see there's no Invisalign tray on this tooth here. That tooth is already starting to rotate, not from any sort of Invisalign button and tray. Actually, there's nothing on that tooth other than an entire Carriere appliance that goes around it, and then a distalizing force, which then acts to close this space, and then the tooth has a vector of force here and a vector of force there, undergone by the adjacent teeth, thereby closing that interocclusal space. So as we continue with the Carriere motion appliance, we should start to see closure of that. With that said, when I'm done with the Carriere motion appliance and I put on a full upper arch Invisalign tray to close this space and further correct the anterior segment, although it looks pretty good considering where we started, I will further rotate that tooth or derotate that tooth into its proper arch form. I'm surprised I didn't see a little bit more rotation of the upper first molars. I don't have an answer to why that didn't happen. I will definitely investigate. Again, I'd love if Invisalign was able to show us how much that tooth rotated or didn't rotate based upon the difference between two scans. They have that technology. They use it for tray assessment in the iTero. They need to export that software into ClinCheck and show us what the degree of movement is for each tooth and break it down into the table like they have at the bottom. I can't wait until they can come up with that, because that can give us a much better assessment of how well we're doing with our treatment modalities. It's very difficult to get better at what you do if you're not assessing the outcomes based upon your original decision making. With that said, I'm very happy where this case is going. We're going to do another 3 months of the Carriere motion appliance using the Force 2 elastics. Force 2 is stronger than Force 1. Again, follow the protocol as outlined in the Carriere motion appliance directions, the packaging that comes with the motion appliance. And then after that, we'll take another scan and do upper and lower Invisalign trays, and then move forward from there. I'm going to end with why did I choose 2 lower buttons on the lower arch. As you can see here, this might be slightly advanced, but the rationale is if you put a button here, then the vector of force is going to be like so, which provides no extrusive force for the lower first molar. When we're trying to level the curve of SPE, it helps to put a button here and then have the elastic create a triangle. And what that's going to do, it's going to create an extrusive force for the lower first molar at the same time as providing a distalizing vector of force for the upper Carriere appliance. So it doesn't hurt to add the button here and then use it as you need. That's my rule of thumb. I did not come up with that. That was given to me by an orthodontist that uses Carriere motion appliances all the time. So anytime you're trying to level the curve of SPE, it makes sense to add a button here. If you don't know, add it. With that said, you lose a little bit of the distalizing aspect of the Carriere motion appliance. So if you don't have to level the curve of SPE, don't add the button. You want to maximize the amount of force that's here. What I do is I tell the patient to mix it up. Sometimes use it one way, sometimes use the other. I don't have a conclusion on whether or not that's the right play, but through discussions with this particular orthodontist, this is something that we came up with together, and he's now employing that particular approach with his patients. There'll be a whole separate video on Class 2 corrections, level and curve of SPE, what have you, but I wanted to go over the specific approach using the Carriere motion appliance. You can order the Carriere motion appliances from Henry Schein Orthodontics. They have metal and plastic versions. The plastic is a lot less visible. We have not had great success with them so far. With that said, there's a learning curve with everything. The metal ones just seem to hold up better. They're just not as aesthetically pleasing as the patient may like. With that said, managing expectations is part of everything we do, especially with orthodontics. So highly encourage the use of this particular tool, and I will do an updated video once we're done this treatment. Take care.